Yes, sir. Yes, we can start.
Okay. Okay. Thank you. So thank you, Nikhil, again for the wonderful distance learning process from your side. Okay, but still I am little, hesitant with all these things. Anyway, so this time what I thought was I have divided into small portions, and at the end of each portion, we will take some questions if there are. Right? Is it possible?
Yes, sir. Yes, sir.
Yes. Now, so today we shall basically discuss the surgical management of congenital cyanotic heart disease, because a majority of the congenital acyanotic heart disease are primarily by catheter interventions, and the so-called indications, the process, it's relatively simple or simpler compared to management of a cyanotic heart disease. So I'll put it in 3 acts, the procedures, the outcome, and of course, how do you clinically and otherwise follow this situation. Now, as you are probably aware, last time I'm a little fond of these pictures. And one picture you have already seen in the last class, that is the 1945 Blalock Taussig Thomas shunt being performed in the US. And on your left hand side top, you see the liberation, that is in 1945, the Second World War ended. And even after ending, that US people put bombs into this. So actually the first 2 pictures were very prominent, but probably as far as the mankind was concerned, the most important significant step was on your right hand side. For the first time, a congenital cyanotic heart disease was being operated for improvement. And there are 3 major people involved in this 1945 business, as you know very well. Helen Taussig, who proposed the idea of a shunt, because for the last 30 years, in 1910 itself, she was thinking that any tetralogy fellow who had a continuous murmur lived longer. So she thought that if you could connect a systemic artery to the pulmonary artery, the baby will live longer. The initial surgeons in our hospital did not accept this concept, but later on, a young surgeon, that is Blalock, came into her hospital, and he was, as usual, young people are more, receptive to newer ideas, and he had a perfusionist, that is Vivian Thomas, and together they created history. Now, on the bottom, you can see 2 people. On your left-hand side is Walter Lillehei, who did the first tetralogy correction in 1953, and on your right-hand side, you can see Kirklin, and there is actually a textbook of cardiac surgery by Kirklin and Associates. So these 2 people fine-tuned the surgery for tetralogy and also many other congenital cyanotic heart disease. So if you look at the credit, the credit goes to these people, starting from our own people, which we have already discussed. And of course, you should never forget Robert Gross, who did the first cardiac surgery ever for a ductus. Then 53, I think that was the turning point. That is, Gibbon invented the cardiopulmonary bypass. And in 54, as I told you, Lillehei did the first ICR for tetralogy of Fallot. In the 70s, Fontan did the palliative correction for a univentricular heart. And in 76, arterial switch was introduced instead of sending for a TGA. And of course, in 1981, Norwood has proposed his procedure for a hypoplastic left heart syndrome. So all these people are really great people. And I had the opportunity to meet once Fontan, and I was telling him, can I shake hands with the living legend? And he was smiling. He's a Frenchman. Now, today, we will basically discuss the major congenital heart disease, that is tetralogy of Fallot with pulmonary atresia, which we call as a VSD with pulmonary atresia, also a transposition, tricuspid atresia, which is a classical univentricular heart, total anomalous pulmonary venous connection on one side, and of course on truncus Epstein, single ventricle atrioventricular septal defect with PS and double outlet right ventricle. Now, these two slides are very, very crucial for anybody taking care of children with the congenital heart disease, especially cyanotic heart disease. And of course, practically it is very useful for postgraduates also, because in the examination they can ask you what is the natural history of the cyanotic heart disease and how can we improve upon this. For example, I will start with the DTGA, which is of course the second most common congenital cyanotic heart disease in the world. Half of them will die without any intervention. At 1 year, only 10% survive if you don't do anything at all. And 10 years survival will be less than 5%. Now, this is very important for a postgraduate discussing cyanotic heart disease in the case discussion, because you don't expect a TGA to survive beyond around 10 years or so, generally. So if you are discussing a 13-year-old cyanotic heart disease who had no intervention, it is very unlikely that you are dealing with the transposition of great arteries. Whereas probably the best in terms of natural history is tetralogy, because by 1 year, still 2/3 will survive without any intervention, and at 10 years, 25%. So which means that if you have a child or an adolescent or an adult without intervention and cyanotic heart disease, you are likely to encounter tetralogy of fallow. Whereas look at the other three diseases, there's a dismal prognosis, almost like a transposition. That is tricuspid atresia, 15-20% maximum. TAPVC, even unobstructed, 15-20% maximum. Truncus arteriosus is again 15%. So all these lesions will not survive beyond 1 year if you don't do anything. Now, if you have a single ventricle physiology, things are a little better. As you can see here, single ventricle with pulmonary stenosis will live, half of them will live up to 1 year, but 10 years it becomes 20%, not bad actually. So another question will come, among the tetralogy physiology, after tetralogy, which has the better long-term prognosis, natural history, the answer is single ventricle with PS, of course, whereas single ventricle with PAH has a less optimistic view naturally. Epstein, the problem is it is so variable. You can have a very mild Epstein, you can have a very severe Epstein who will die by newborn. And very importantly, if you take 100 Epstein, half of them would die by newborn period. And atrioventricular septal defect is actually not a cyanotic heart disease, but if they develop pulmonary stenosis, you will call it as a cyanotic heart disease, tetralogy-like situation, and 2/3 of will survive up to 1 year, just like our tetralogy. So ultimately, if you look at a survival of a congenital heart disease, cyanotic heart disease, and infant repair, nearly all congenital cyanotic heart disease will have a poor 1 year survival, which means that surgery for congenital cyanotic heart disease is infant surgery, because at the 1 year, the infant must be with a repaired heart. That is the basic principle. Is the pediatric cardiac surgeons. They want a child with cyanotic heart disease to be free of the disease and a reasonable repair at the first birthday. So I would say congenital cyanotic heart disease surgery is actually infant cardiac surgery. Now, there are 4 varieties, actually it's not 5, it is 4 varieties of congenital cyanotic disease. For example, you will have 2 ventricles, good ventricles, and 2 circulations. For example, LV classically would be a tetralogy of fallow, TGA. They have good 2 ventricles and 2 systemic and pulmonary circulation. They may be crisscrossed, that is a different thing. Secondly, you have 2 ventricles, but there is only 1 circulation because both the ventricles pump into a truncus, which again gives rise to indirectly to a pulmonary artery. Then you will have what you call as a univentricular situation where you have only 1 ventricle and 2 circulations, which is tricuspid atresia, single ventricle, what we call as a univentricular heart. And lastly, you have one ventricle and practically only one circulation, that is on the right side, that is hypoplastic left heart syndrome, which means the prognosis, even with surgery, is not very great. So now basically we had the natural history, and then we come to the second part, that is timing and method of surgical intervention. Now, congenital cyanotic heart disease surgery, we could divide them into three parts of the spectrum. One on your left hand side is palliation, on the other side is correction, and in between something like a definitive palliation. Now, what is meant by palliation? Temporary thing like a bladder shunt or a Glenn shunt or a banding, whereas a total intracardiac repair would be the correction. Whereas there are some situations where you actually only palliate, but that is the definite treatment. There is nothing beyond that. And classical example is a Fontan surgery. So that is also important. So you should remember that the treatment of choice for a univentricular heart is Fontan or TCPC, but they remain actually the best and definitive palliation. So you should know the limitation, whereas a tetralogy fellow or a transposition, you basically are correcting both the anatomy as well as the physiology. Suppose you deal with a congenital cyanotic heart disease in newborn baby or an infant. You decide whether the baby is stable or unstable. If the baby is unstable, naturally, the baby may require medical measures as well as palliation. Whereas if the baby is stable, we can continue for some time and treat them in the appropriate time. That depends on the conditions. So ultimately, if you have a cyanotic congenital heart disease, they will have baseline cyanosis, that is hypoxemia. But some of them will have more hypoxemia than anything else, that we call as a hypoxemic situation. Some of them will have hypoxemia, but the dominant feature will be heart failure. We will come to that. Then, of course, there are certain cyanotic heart diseases like a tricuspid atresia with a transposition, with a shock they can appear. I am not going into that. So I am looking at two areas, the hypoxemic cyanotic heart disease and a cyanotic heart disease which has primarily heart failure. So look at hypoxemic cyanotic heart disease, where you may need some medications, some interventions, and of course surgery. Whereas those with heart failure would require medication and some surgery, but not many interventions. The medical management of a hypoxemic baby, as you know very well, is one, to try to maintain the ductus. You give oxygen. Most of them are sick babies are in metabolic acidosis. You give alkali. Some of them may be dehydrated. Some of them will develop spell. So you treat spell, and to prevent spell, you give beta blockers and iron. So they form the medical management. Now, hypoxemic congenital cyanotic heart disease may require intervention, and the classical example is a balloon atrial septostomy. And we used to have actually blade septostomy in an older baby who come late with the TGA, but it's not now done because basically, practically all of them will come very early to the pediatrician and the pediatric cardiac surgeon. Then a new thing is called ductal stenting, which you are very aware of, keep the ductus. Then RVOT perforation in critical pulmonary stenosis, pulmonary atresia, RVOT stenting in a severe tetralogy of valve. You have a critical valvular pulmonary stenosis, which will require a balloon pulmonary valvotomy. These are interventions, but the what you call as the number one, the first ever intervention in a congenital heart disease is balloon atrial septostomy, which otherwise called Raschkind-Miller procedure. Unfortunately, people forget the name Miller, only remember Raschkind. Now, if you have a hypoxemic congenital heart disease, bladder-toxic Thomas shunt is the shunt, because it has now 55 plus 25. It has remained there for 75 years. They're one of the real BT shunt. Then Glenn shunt for a univentricular heart, which we will discuss later. Then there are other shunts like Waterston, Cooley, Potts, etc., which are of mainly historical importance only. And there is something called a central shunt. Now, this is one group with hypoxemia, cyanotic heart disease. Now, you have a cyanotic heart disease who have also heart failure naturally. Medical measures are very important, like inotropes, diuretics, ACE inhibitors, oxygen for hypoxemia, and sometimes they may need a ventilation before going to cardiac surgical procedure. And perhaps the only most important single intervention by surgery is a pulmonary artery banding, about which we shall have a discussion later. So the basic thing is that what I have told you is that you have a cyanotic heart disease who may be stable or unstable, and who may be having predominantly hypoxemia, for which medical measures are there, intervention measures are there, and surgical measures are there. Whereas those with severe heart failure, like an admixture lesion or a transposition with a large VSD, there may be both hypoxemia and heart failure. You may need medical management as well as reduce the blood flow to the lung by pulmonary artery banding. Now, I thought that at this point, I don't know if there are any queries you can ask. Nikhil can be the spokesperson. Otherwise, we will go on to specific situations. Shall I move? Nikhil? Shall I move towards the next part? Can you hear me?
Yes, sir.
Yes, okay.
Yes, sir.
Yes.
Yeah. Please. Shall I? We will come to the what you call as intracardiac repair, what we call as ICR.
Yes.
You please
Sir,
ask.
can you
Yeah.
hear us, sir?
Hello, I can hear you.
Okay. Sir, RVOT perforation, I wanted to ask where it is.
Yeah, RVOT perforation actually basically, for example, in Sri Chitra, people have done RVOT perforation mainly in a critical pulmonary who come very sick and it's very difficult to manage. We have done in Chitra when we were student. I mean, when I came out of that period. Now it is sometimes done, not very commonly, because many of them will have a ductus and they will have a ductal stenting. And I have one of my junior colleagues, called Krishnamurthy in Sri Chitra, who does this for a critical pulmonary stenosis. In many other centers also, I suppose. Even in Kerala, I know only about Kerala, where you have Amrita also, they once in a while do. And sometimes they, what you call the stiff end of the guide wire can be used for this thing. I think you also know that radio frequency ablation also has been used to perforate a thin atretic membrane in the RVOT. So three situations. You can simple balloon dilatation or a RF ablation or a
Sir,
yes.
they ask about balloon ablate.
Yeah, because I am giving a special importance to three very important palliative procedures: balloon septostomy, BT shunt, and Glenn and PA banding later. So we will come to that because there are many questions will be asked in the examination. I have chosen those specifically.
Thank you, sir.
Okay. Now, at that point, if you have any doubt, any extra points you want to ask in terms of examination, I will definitely will be able to help you. Now we come to the second part, what you call as the intracardiac repair. What do you do? I told you before, you can have a definitive ICR as in Tetralogy of Fallow, or a definitive palliation, which is called a Fontan or a TCPC for a univentricular heart. Now, this I think is a very, very crucial point slide for not only us, for a pediatrician also. Because if you plan surgery for a congenital cyanotic heart disease, this has to be done today if there is an obstructed TAPVC. There is no point in waiting for one more day. The name is today. The term is today. And this week, if you diagnose a DTGA, that has to be done this week itself. Unobstructed TAPVC this month itself. Tetralogy this year. Whereas Epstein, milder forms may be later. I think this philosophy you should inculcate when you go out and practice cardiology. I know that majority may be practicing adult cardiology, but still, if you have encountered babies with this cyanotic heart disease, this is the very, very, very important philosophy. So sometimes you do it today itself. There is no point in waiting for one more day, the baby will die. DTGA this week, we want to prevent doing a sending operation. This month, unobstructed TAPVC, because the interim period of waiting has a very high mortality. They may not die of a heart failure, they will die of a pulmonary pneumonia, which we have seen during my for the last 30 years or so. And of course, this year, that is tetralogy. And Epstein all depends on what you call as the various features, which again we will discuss. It's a very important thing. Now, please be very careful. That is, this I have prepared for you a sort of a, not an algorithm, what you call as 4 important aspects of an intracardiac repair. When we do an echocardiography in a suspected congenital cyanotic heart disease, and you confirm that this is a congenital cyanotic heart disease, you have to decide even for the surgeon, because you are looking at a cyanotic heart disease with an eye and mind of a surgeon, because your echo report has to be useful to him to make a decision. So at that particular point, you have to make a decision whether this child will be fit for a biventricular repair, or is the child only for a univentricular repair. For example, tetralogy, things are very simple. It is a it's a candidate for a biventricular procedure. Whereas tricuspid atresia, naturally, it goes to the univentricular procedure. The next question is that, do we need a conduit? Some, for example, I will come with examples. Some will need a conduit, some may not need a conduit initially. Then rarely some of them may also need a permanent pacemaker implantation, which we will come to. And lastly, when you counsel the parents, that you should decide and tell them whether this particular congenital heart disease may require a redo procedure later. See, some of the redos we cannot predict, but some redos we can predict that this child, your child, we have done a surgery, a corrective surgery, but sometimes you may have to have another surgery also. So that also. So these 4 points have to be remembered whenever you evaluate and counsel a congenital cyanotic heart disease. I will give you examples, then you will understand. Then this redo actually can be catheter procedure also, surgical procedure also, and it can be an anticipated surgical procedure. For example, you're putting a conduit naturally in a very young child, you may require a redo. Whereas a tetralogy of fallow, if they develop a severe PR in adulthood, they will require a redo procedure. For example, these 4 points, you know that 4 points, no biventricular versus univentricular, conduit versus no conduit, PPA versus no PPA, and no, now it is, the term is PPE, I suppose, that is personal protection. Whatever. Now, so for example, tetralogy, very sure it is a biventricular repair. There is no need for a conduit. It is not a pulmonary atresia. And generally, they don't go for a complete heart block. And of course, usually they do not require a redo procedure. Look at the example, tricuspid atresia. It's a univentricular repair. And if you do a what you call as a outside the heart a conduit, you may need a conduit. And usually they don't require a pacemaker. But if you do a procedure which is other than the lateral this thing, you may I will come to that later when we talk about tricuspid atresia. Suppose you have a truncus arteriosus. It's a biventricular because both the ventricles are very good ventricles. but you will invariably require a conduit. And usually, as you know, truncus operation is usually done before 2 months. So naturally, you will require a redo for the conduit replacement. And generally, there will be no need for a pacemaker. Now look at a rare example of a LTGA VSD PS. Here you have two very good ventricle, a large huge defect with PS, which will behave like a tetralogy fallow. So naturally, it's good for a biventricular repair, but you will also require a conduit. Because you need a conduit in a younger child, you may also require a redo procedure. And very importantly, LTGA, as you know, is notorious for development of complete heart block. So that complete heart block may develop during procedure also, which may not come back. So you must tell the parents that there is always a possibility that your child may require a permanent pacemaker. This is a very important thing, especially in a private sector, because the cost is also very important. It's not borne by the government. So first, you will talk about a biventricular repair of one type. This is, I have artificially classified this for your convenience. Biventricular repair, but one type, that is offering near cure. For example, tetralogy fallow. You do it, good. TGA. You do an arterial switch, very good. You do a Schumacher procedure, TAPVC, the baby will do very well. Now, among the biventricular repair, the results are between cure and palliation, because some of them may require a redo procedure. For example, some of the double outlet right ventricle, tetralogy fallow with pulmonary atresia, truncus arterios, they will require a redo. So I will call them as biventricular repair, but the results are little less than that of a tetralogy of fallow. And finally, the third part is what you call as a univentricular repair, which we call as definitive palliation. Why definitive palliation? Because it is palliation, but that is the definitive procedure for that particular congenital heart disease. For example, tricuspid atresia, etc. Now, this is another what you call a stop for thinking. And incidentally, the picture you see on your left-hand side top in the screen is a very famous sculpture called The Thinker. It was by Rodin in France. And of course, on the right side, it's only a mic. It looks something different, but it's only a no art. So, do we have a conversation now? We will. Am I going too fast or something, Nikhil?
No, sir. You are going correct on this. No, sir. You are going correct on this.
Okay.
Sir, one doubt, sir. Question they always ask.
Yes.
Why we get heart blocks in CCTG, sir?
Because you know, basically you look at the AV nodal junction, the AV junction, then fibrous this thing where atrium is connected to the corresponding ventricle, and you see the heart disease where you have this AV junction problem, like endocardial cushion defect, classically atrioventricular septal defect, and you have this RA connected to the left ventricle. So there is a problem with that junction, AV junction. So whenever there are conditions where you have a AV junction problem, naturally the conducting pathway is little longer, and if it is longer and slightly what you call as what is malpositioned or something, you are likely to have a complete heart block. And the two classical example is a LTGA because of the AV concordance and AV discordance and AV concordance, and atrioventricular septal defect because of, again, the problem in that particular area, endocardial cushion area. That is what we call as an AV junction area. These are the two conditions, and this is probably the most likely reason for a complete heart block. And of course, we do see complete heart block temporarily in postoperative patients in many conditions. For example, whenever people fiddle with the atria, like in sending, etc., temporarily. Even in TAPVC, we have seen temporary heart block, but they usually recover completely. Going for a corrective surgery, you must inform the parents that the child has a small chance of, a significant chance of developing post-operative complete heart.
Okay, sir.
Okay. Now we come to the what you call as the cyanotic congenital heart disease, tetralogy of Fallot. There was, of course, a time when we were postgraduates in pediatrics, and we only knew one condition. What is that? Tetralogy. A child comes with blue color, there is a murmur, and that child is having tetralogy. Only when I went for, really, when you went to Chitra for a DM training, you find that the so-called all that looks blue are not tetralogy of Fallot, but I think it still continues the number one congenital cyanotic at any age, except for a newborn period. At any age, this happens to be. And the most common surviving cyanotic heart disease in adulthood is tetralogy, like an acyanotic of ASD. This is very important. So, which is very important for your exam also, because if you have an adult with a cyanotic heart disease, one differential diagnosis mentally, you should think of a tetralogy of Fallot. And you know these three persons already. And initially people started a two-stage repair. That is, initial BT shunt was there, it was done, and then a tetralogy of Fallot. I still remember during my DM days in Chitra in 1993 and all. It is very ancient. Now you know how ancient I am. We used to have a BT shunt followed by a tetralogy, or usually we used to do 3 or 4 year tetralogy. Now it has become a single stage, and now it has become an early single stage, very early, somewhere between 3 to 6 months. We will discuss that. Now, how do you manage gross broadly a tetralogy of Fallot? If the tetralogy of Fallot is like a sick in the newborn itself, in the early part of time, there is always a point that you can possibly go for a ductal stenting or an RVOT stenting, and of course a BT shunting in the newborn itself. So now you know that in pediatric cardiology discussion, there is always a debate whether a tetralogy or a pulmonary atresia with a VSD in a newborn should have a ductal stenting or a neonatal BT shunt. Slowly people are moving towards ductal stenting, not only because they are becoming good in this, but because the number of BT shunts are coming down. So we have less of surgeons having good experience with the neonatal BT shunt. Sometimes the tetralogy will be reasonably comfortable. They are called non-palliative. And finally, they also will go into intracardiac repair. Now, the question is, what is the optimal age? The optimal age is somewhere between 3 months to 12 months. And secondly, very importantly, it's a transatrial approach. We were students, it was a transventricular approach, which caused problems of ischemia because they may be cutting coronary artery branch, etc. But it is transatrial approach. And as we will come again back to this, is avoiding a transannular pass as far as possible, because that, of course, would later on transform this patient into need for a pulmonary valve replacement. And that is the point. And you have to eliminate an RVOT gradient, remove the muscle bundles, etc. That is the basic principle. So the standard procedure is a VSD closure, infundibular resection, if necessary, put a patch, pulmonary valvuloplasty, because 30% of tetralogy are PS also, and of course, with great reluctance, only if it is needed, transannular patch is given by the surgeons. Surgeons are not at all fond of this transannular patch. So the modern tetralogy surgery is that early surgery, avoid transannular patch, should be less than 15% in a large center, and you repair the pulmonary valve and preserve the pulmonary valve and accept. This is very, very crucial, because yesterday only I had prior to this talk, I had a discussion with the HOD of cardiac surgery. Dr. Baiju is a close friend of mine and is an excellent surgeon. And he was saying that you must accept a gradient of around 30. So you don't have much of a pulmonary regurgitation. So avoid TAP, preservation of pulmonary valve, and transarterial approach, and accept. So the problem is this is a trade-off between mild PS versus PR. We would always prefer mild PS. Because I still remember during our days in the 90s, we, as a second year resident, we used to do post-operative tetralogy fellow, and you could see a capacious RVOT with hardly any gradient, but some degree of PR. That is not very good because they are going to become candidates for a pulmonary valve replacement. So the current is when there is a trade-off between mild RVOT obstruction remaining and PR remaining, you would always prefer to have a mild RVOT obstruction. It's a very important lesson to be learned. What is the hospital mortality? 4%, less than 4%. It's a general, can vary from 2 to 4%, but average less than 4%. And probably you should look at, I think there is an NEJM review article on a 30-year survival of a tetralogy, which is 90%. You should see that. 90% survival, and redo, especially for a pulmonary valve replacement, is around 0.8% per year, and that's beyond. See, well, that is a slight problematic thing, that they will do very well for first 30-40 years, and beyond 30 years, I think there is still a chance for a sudden cardiac death, mainly because of a malignant arrhythmia. Right. Now we come to the palliation, ductal stenting, RVOT, and we will not go into detail because there are interventional procedures, RF ablation as I told you, but the shunt is a Blalock, Taussig, Thomas shunt, or sometimes a central shunt, subclavian artery to the MPA, not the branches. What you do is you connect subclavian artery to ipsilateral pulmonary artery. You know it very well. One is classical, another is modified. Classical is not that generally. Modified can be, both classical and modified can be done on the right side or on the left side, and with Gore-Tex tube, PTFE, standard thing, 3 mm, 3.5 mm. The size will depend upon the heart and the surgeon. Now this, I think, will give you a very clear picture of what is meant by a classic and what is meant by a modified. A is classic. As you can see here, the innominate artery divides into two. One goes to the brain, another goes to the arm, and that is subclavian artery. You cut the subclavian artery, you sacrifice the subclavian artery, bend it down easily into the right pulmonary artery. So it's a side end to side anastomosis. This we does not use any foreign material, and this is a classical VT shunt. Whereas on your right hand side, B is a one where there is side to side communication between the RPA and the right subclavian artery. This is using a Gore-Tex. This is called a modified VT shunt. And one practical thing in the examination is that the need for a low dose aspirin is there for Gore-Tex VT shunt, whereas it is not needed for classical VT shunt. But now classical VT shunt is practically extinct, and even the VT shunts are now coming down in our, because more and more surgeons are doing early reparative surgery. So in a way, VT shunt can be done at any age, but it has a certain mortality. So you see that 5% or 4%, which is equal to that of a tetralogy repair. That is why, for example, you have a 4-month baby who has multiple spells not responding. Earlier we used to do a VT shunt. Now the surgeon say, anyway the baby is 4 months, I will do a intracardiac repair, avoiding this extra mortality. The problems are that of a pulmonary edema, because if you choose a larger than what is required a Gore-Tex tube. You can have a sudden volume overload into the LV. You can have an LV dysfunction. You can have a coronary steal is possible, and you can get blocked naturally. So the situations, that the part I will come back again. So it is becoming less common. Even the modified ventilation is becoming less common. Currently, you are doing it for a pulmonary atresia with a VSD because you have to have a reasonable blood going into the lung sometimes, and first part of Norwood, which we will discuss later, and single ventricle with severe PS, etc. Poor anatomy, but you should know the mortality is around 5%. But now in tetralogy, these are the three situations where we may still require a thing. One is an associated coronary anomaly, and now that is also to some extent okay, because nowadays it's a transatrial approach. You have multiple VSD, sometimes you cannot close and all, and of course a very poor PA anatomy. We may do a ventilation, allow them to grow, pulmonary arteries to grow, and later on do a tetralogy surgery. So then you have the extreme form of tetralogy of Fallot, which we call as a pulmonary atresia with VSD, or a tetralogy with pulmonary atresia. Now here the basic thing is that you need additional supply. The blood is not going to the lung. So that lung can get blood either two sources. For example, if you have a PDA, it goes to the PA, one source. If you have a MAPCA, actually, many MAPCA, maybe 3 or 4 or 2 will be there. They will directly go to the lung segments rather than going to the hilum, pulmonary artery. So many times, a pulmonary atresia with a VSD will have a dual lung supply, one from the ductus, another from the MAPCA. That is the problem. So here, the palliative procedure is definitely amputation. There is no doubt about this. You do amputation. And what is the repair? Same, almost same like tetralogy. That is a VSD closure. But here you need an RVPA conduit, and you may have to do pulmonary arterioplasty, a reconstruction, and come to another very important term. It's called unifocalization, which we will discuss a little later. And of course, mortality is marginally higher. Instead of less than 4%, it will be around 6%. Whatever mortality figures I have done is a general mortality. But there are centers who may have much better survival pattern post-operative. Now, this unifocalization of MAPCA, that is basically, MAPCAs are coming from either aorta or subclavian, larger branches of the aorta. They directly go to a particular lung segment. There are, as you know very well, there are 20 lung segments. So that lung segment will get blood sometimes through the pulmonary artery because there is a PDA, and also from the MAPCA. So the lung tissue or the lung vascular area, one of the 20 areas, they may get dual supply. That is not good. So what we want to make it only one source, right? Only, for example, if you have it's like a democracy being converted into a totalitarian. There will be one single source of power, and that is what is meant by unifocalization. So this is done in pulmonary atresia situation. All 20 segments of lung are unifocalized to PA. So what you do is that you cut the main MAPCAs from the source and connect it to the and basically connect it to the MPA segment, so that everything will go to through the MPA only one source. So disconnect all MPA, MAPCA, maybe 2 or 3, they will be connected to the PA. And there is, of course, this RVPA conduit has to be made because of a pulmonary atresia. So what happens is that everything has to go to the central station, that is main pulmonary artery. The conduit, the MAPCA, everything has to go to the. So that only supplies the lung entirely. So there will be only one source of blood to the lung. Otherwise, what will happen is some segments may be getting excess blood. They will develop a pulmonary vascular occlusive disease in that particular area. And this is the best way. You put a VSD close, you put a conduit, and make sure that RV blood goes to the pulmonary artery, and the rest of the blood also goes to the pulmonary artery. And pulmonary artery is the central supplier to the entire lungs. That is what is called as unifocalization. Now we have covered a very important area, that is tetralogy fallow, and a variant, extreme variant of tetralogy fallow, what we call as a pulmonary atresia with VSD. So right now, I think maybe ask some.
Sir, unifocalization figure was can you just explain, sir?
Yeah. See, what happens is that, so you imagine a tetralogy, right? You have a large VSD. There is pulmonary stenosis. Suppose pulmonary atresia is there, as you know very well, the blood cannot reach lung. So the only way by which the lung gets blood, there would be a PDA. Now, PDA is connected from the aorta to the MPA near the LPA-MPA junction. So whatever blood is coming through the PDA, with the help of PDA, is being distributed normally into both lungs. So every lung area is getting that blood supplied by the PDA, right? That is no confusion there. But suppose along with that, suppose there are two MAPCAs, major aortopulmonary collaterals, coming from where aorta, descending aorta, or underneath the arch of the aorta, or a subclavian artery. Suppose one goes to one lung, another goes to one particular segment. So that segment is now getting two sources. One, a little bit of blood coming through the ductus, and another significant portion from the MAPCAs. And you know, MAPCAs are basically under aortic pressure. It comes in with a higher, definitely higher pressure, naturally. So they are getting dual supply. So that we don't want. You don't want lung segments getting dual supply. We all want blood to come from the central portion. So that is why we do this thing. So you can do it in two ways. For example, you can do a conduit. So make sure that the RV blood goes to the pulmonary artery, and you can destroy the MAPCAs by either removing the MAPCA, or even putting what you call as closing of the MAPCA by an intervention. But this unifocalization is aimed at connecting those things into the main pulmonary artery, so that every blood which is where is destined to go to the lung goes to the pulmonary artery, and it is the pulmonary artery which supplies the blood. You get the point? So basically, it is a dual blood supply to the lung segment is converted into Unitarian blood supply. That is why the word unifocalization implies in a pulmonary atresia. Are we okay?
Yes, sir.
No, some people do it in the same sitting. Some people do it in a separate sitting. It all depends on the baby and the age, the surgeon's enthusiasm, not enthusiasm, the capability, all those things are there. But why I specifically mentioned unifocalization is that when I joined for a DM, it took me almost 1 year to realize what this unifocal meant. So I thought this particular area should be very clear. What you remember is this: in a pulmonary atresia situation, the lung segments, 20 different lung segments may be getting blood from two sources. We don't want that to happen. We want blood from only one source, that is from main pulmonary artery. So for that, we are anyway connecting RV to the PA. Then we are for unifocalizing this, or removing the unifocal. Removing the MAPCA by a plugging or whatever, coiling. Now, is a difficult area.
So one more question.
Yeah. Yes, definitely.
Sir, how to explain natural history of patient?
Hello.
Hello.
Yes.
Sir, how to explain natural history of petition?
How to explain?
Sir, natural history of petition.
Petition. That I will come to that because petition. I told you petition, pulmonary artery banding, balloon septostomy. We will take it's as an individual entities later because they are very important not only in clinical medicine as well as in exam purpose also. So we will come to that later, definitely. Especially the evaluation. For example, I will tell you anyway this way. For example, if you take a what you call as a unmodified or a classical petition, they don't require low dose aspirin. They are less likely to block. So it may last for so many years. Maybe see, for example,
Why is it, sir?
Because
Sir,
you are
why
using
classical medicine doesn't require aspirin?
because you are using the natural material. We are not using any artificial material. You are actually using the subclavian artery. It is actually subclavian artery which goes into the right pulmonary artery. So it is artery to artery. Absolutely no tissue material. It is the most natural thing in the world, right? That is why you don't need an aspirin. But still, there is always a possibility of a block, but very late. So in fact, when I look back, our batch's examination had one adult person who had only BT shunt done and then he did not report. They came as for a case presentation. Then it was still working very well. Whereas naturally, Gotex is involved. Naturally, there is a tendency for blocking. And even if you give aspirin, I think many people will go into a shunt block, partial block at least. So you may, but only thing is, you have a shunt at 4 months, you can do the surgery, total surgery by around 2 years, so you can avoid blocking of the modified BT shunt. And of course, you are removing the risk of limb ischemia because you are not sacrificing subclavian artery. And it's easier. Surgeons say that it is much easier than doing it. And another very important thing is in the examination, they will ask you the right arch in tetralogy. What is the significance? One point is that 25% of tetralogists will have a right side aortic arch. That is one thing. Then they will ask you, is there any practical implication? The practical implication is mainly that if you are contemplating a classical BT shunt, you should do it on the opposite side. If you have a right arch, you do it on the left side. If you have a left arch, you do it on the right side. But with the modified BT shunt, that does not, and that issue does not exist. So now it is basically because as you can see before, see, I'll show you the picture. See, you look at picture A, where you can see the pulmonary artery coming up and dividing, and you can see the aorta is basically arching to the left, right? This is a left-sided aortic arch. So naturally, when you have the arching out to the left, the first artery is a brachiocephalic or innominate artery, which means the subclavian artery is very close to the right pulmonary artery. And if you can mentally imagine that aortic arch to be a right-sided aortic arch, the branch distribution goes differently, and the subclavian artery is no longer near the pulmonary artery. It has to be closer to the left pulmonary artery. So you imagine the same arch going to the right. This is a left arching, as you can see very well. So left arching, right, and right arching, left BT shunt.
Even for the modified less length of conduit on the opposite side.
Yeah, that is also. But there is no specific requirement. You don't need to worry about them.
More the length of conduit, more chances to be the
Block. Yeah, but yeah, I agree. That is also a point. I agree that point. Maybe we will. I think I'll have to talk to my friends about that. Shall we go ahead? Nikhil?
Sir, one more question.
Yeah.
Sir, this late presentations who underwent mutation, who present in at their 20 years or 30 years, who were never presented before or last follow-up, shall we take for complete intracardiac repair, or we shall do only medical follow-up? Who are late presentations, like in 20 years, 30 years, who underwent only mutation?
And they are, but they may not be doing well. See, they will have significant polycythemia, and they will definitely may have a reasonably good pulmonary anatomy. And there is definitely, I think there is an indication for a intracardiac repair. Intracardiac repair in an adult may have additional problems, mainly because of the polycythemia and the disseminated intravascular coagulation issue post-operatively. But I think they should be offered, because if a very complex congenital heart disease in adulthood, adult congenital heart disease with a very complex congenital issues can be offered a surgery, you must definitely offer them a choice of this thing. Only problem is, because of a long-standing classical BT shunt, there is always, all the BT shunt, there is a small risk of a pulmonary vascular occlusive disease. But pulmonary vascular occlusive disease is less common in a natural shunt than the Gore-Tex shunt, because Gore-Tex shunt, we may overestimate the size of the Gore-Tex, whereas in the natural, it is a natural artery, but still they may have PVOD. So naturally they would require a full-fledged catheter, catheterization, pressures, all those things before contemplating a surgery. I think all tetralogy fellow, and every surgeon will agree that all tetralogy fellow will deserve a tetralogy, but it's always the question of those people. See, for example, even I still remember a DTG, a neglected TTG, a simple ordinary TGA with a moderate sized ASD, refusing a surgery in our institution, my previous institution, and coming back after 4, 5, 6, 7 years with severe blue color. And I think the surgeon did a sending. Primarily, it's a palliative sending. Why? We wanted to make the child comfortable, more or less cyanotic, and maybe it may not alter the natural history. He may die prematurely, but as long as that person lives, he should live reasonably comfortably. So tetralogy is definitely a much better proposition. Right? Now we have the duct-dependent systemic circulation. We talked about pulmonary atresia, and this is basically an aortic atresia. This is a very tricky situation. Like basically, what do we do for a Norwood procedure? So you should mentally imagine that you have a left ventricle and a right ventricle. Right ventricle is good. It is going to a good pulmonary artery and the branch. Left ventricle is not good. It is going to an artery. It is stopping short at aortic valve. There is an aortic atresia, and aorta itself may be definitely smaller. There may be arch hypoplasia, all those things. So you can imagine that on your right hand, on your right ventricle, good pulmonary artery. Whereas on the left side, you have a bad LV, no aortic valve or aortic atresia, and what you call as a hypoplastic or whatever aorta. That is the situation in a hypoplastic left heart syndrome. So what you do is, very interestingly, you are cutting actually essentially a good thing. That is, you are cutting the main pulmonary artery from the right ventricle. You simply cut the pulmonary artery from the very close to the origin. And then what happens is that the pulmonary artery blood supply has to be maintained. So that is maintained by a BT shunt. So that we will see. But then you are remembering that no blood goes into the aorta from the left ventricle. So what you do is a systemic circuit is connected to the RV through the PA stump. So but that what you do is that if you have a PA stump is there, the PA stump is coming from the right ventricle. So blood in the right ventricle goes to the PA stump, right? The rest of the PA has been taken, ligated, disconnected. So from that PA stump, it can be connected to the aorta. So the aorta itself will be small. So what you do is you augment the aorta by a patch. So blood will go from the right ventricle through the PA stump into the slightly reconstructed aorta and will supply the body, right? And the lung will be supplied temporarily by a BT shunt. Where does this BT shunt get the blood? From the aorta. And where does the aorta get the blood? From the right ventricle. So you have a right ventricle going into the aorta supplying everything, and from that to the lung. That is basically the initial part. But you must remember, this is a first stage. Second stage, basically, you need a Fontan-like correction. So now I will read this. You have a pulmonary circuit is disconnected, and the pulmonary circulation is maintained by a BT shunt. Right. Now you are wondering, how can a BT shunt work? Because there is no blood reaching the aorta. So that is basically by because you are disconnecting the pulmonary artery from the RV outflow, so that PA stump will be there, and the stump will be connected to the aorta. But the aorta may be a little small. So what you do is, as you can see on your right hand side, you can cut a linear incision. There we put a pericardial patch or something. So you make the aorta bigger enough to accept the blood coming from the right ventricle, because right ventricle is giving rise to a normal cardiac output. It goes into the aorta, and from the aorta to the body, and from the aorta part of it is supplied to the lung also. So things go, they do not die. That is the first stage. Later on you can go for a Fontan procedure. So that is the essential principle. And I know it's a very tricky area, but the basic principle, I think this slide, when you get this slide through Nikhil, you should read it and try to imagine it in the real thing. Now, the second most important congenital heart disease is a transposition of great arteries. I think these are all landmark surgeries, like Tetralogy, Jettine surgery. They are landmark situations. Now, this is the standard procedure for a DTJ. We'll come to that in detail. You have a TGA with intact ventricular septum, where there is, if at all, there is a VSD, very small VSD. And the standard choice is arterial switch operation. And if the child comes to you beyond 2 months, you generally may have to go for a atrial switch, which is called a Senning procedure. But still, we can try to get into an ASO by a two-staged ASO. That is basically by banding the pulmonary artery. Now, why are we not doing an arterial switch beyond 2 months? By 2 months, the left ventricle will be basically getting exposed to a lower pressure pulmonary artery, and they will start to regress, and it may not be able to take up the systemic pressure. That is why beyond 2 months, you don't do you don't do arterial switch. Actually, you should do an arterial switch before 3 or maximum 4 weeks. And if there is a delay in coming, you can still go for an ASO, because that is the arterial anatomical correction. So you can do prevent regression of left ventricle by putting an obstruction, that is called pulmonary artery banding. Wait for some time, and then if you feel by various means of echocardiography, you feel the LV is fit enough to manage the systemic pressures, you can do a two-staged arterial switch operation. Then if you have a TGA with a large VSD or a PDA, again simple arterial switch with a closure of the defect. But here one good thing is that if there is a large VSD, the LV pressure will not come down. LV regression may not take place for a longer period. So you have a little more time to do an arterial switch operation. And lastly is a DTGA VSD PS, and which basically behaves like a very severe fallow early onset cyanosis, good murmur and all, when you do a Rastelli procedure using a cone tube, which is important. Now, the question is, this man is rash-skinned. I have never been able to find out the picture of a Miller. Sometimes history forgets some people, and the history will remember only a few people. Like our neurology, you have a Guillain-Barré, Landry. On Landry is always, I will not remember, absolutely. So here, the question is, suppose you have a TVGA coming up, they will be diagnosed to have a blue color with hardly any murmur. The general policy will be in a newborn setting. Naturally, we will start with a prostaglandin E and then transfer to a cardiac center. Now, some centers will basically, that is why I put 2 question marks. Some centers will stabilize them with the prostaglandin, acidosis will be corrected and they will go directly to arterials. Some centers may prefer to do a balloon atrial septostomy and then send for a arterial switch. They all, I think to some extent it is institutional. Some are very, very vehement that there is no need for a BAS, we will do it after PGA. Some centers say that BAS can be done. Now the point is, some surgeons feel that if you do a BAS and the saturation improves, the hypoxemia may be better, everything may be better. So they feel that a BAS may be necessary. But sometimes another practical thing will come up, especially in a large volume center. There may be waiting people. Babies will be waiting with other causes also. So if there is a waiting for 3 or 4 days and not, it is always better to do a balloon atrial septostomy and plan for an arterial switch. Now, one practical point which I missed, I did not put that slide on that, is the standard question is there for how will you know the balloon atrial septostomy is successful after the procedure? So that is a standard question. The answer is 1, the saturation goes up at least by 10%. It goes up to almost 80%. Usually the baby will be around 60s and saturation will definitely go at least by 10%. That means it's a reasonable success, one thing. Second, if you do an echocardiography, there will be a good flap of interatrial tissue moving around. That itself shows that our pulling was good enough. That is the second point. And thirdly, before coming out of the LA, you measure the pressures of RA and LA, and the interatrial gradient is less than 2 millimeter of mercury. So these are the 3 standard answers for a standard question. How do you assess the success of a balloon atrial septostomy? One is the elevation of increment in saturation. Second, interatrial grading by catheter, and a good flap by echocardiography. These are the 3 points to assess the balloon atrial septostomy. Now, there were periods of sending. It is called atrial switch. That is basically we are directing superior vena cava and inferior vena cava blood to the right atrium. But from the right atrium, it is directed to the mitral valve, and that goes to the left ventricle. So naturally, left ventricle will give rise to pulmonary artery, goes to the left. Very good. And the pulmonary venous blood will go to of course, to the anatomical left atrium, but it will be directed to the right ventricle through the tricuspid valve using a valve. So the whole, you are actually correcting, you are doing it an atrial switch. This is a physiological process. It is not an anatomical process. That is why it is inferior to arterial switch, which is an anatomical process. So this is called a Senning procedure. And generally, it does not use any artificial tissues, unlike mustard operation, which is basically the same thing, atrial switch. See this picture. If you look at this picture, you can see the superior vena cava, the blue one, inferior vena cava, the blue one, and there is a baffle created. So that baffle takes both IVC blood and superior vena cava blood and goes into the mitral valve. And from the mitral valve, it goes to the left ventricle, and from the left ventricle, it goes to this thing. Now, those blood which comes to the left atrium on both sides, 2 on the right and 2 on the left, it goes behind the baffle. As you can see a picture, white arrow on the top, and that goes to the tricuspid valve, right? And from the tricuspid valve, it goes into the right ventricle, and ventricle gives rise to aorta. So everything is fine, saturation is normal. So you have a baffle is basically for systemic venous flow, whereas behind the baffle, the blood will flow into the tricuspid valve. This is called the intra-atrial baffle, otherwise called mustard or sending. Mustard uses artificial tissue. Sending does not use artificial tissue, so they are less prone to atrial arrhythmias. That is why sending is preferred. I feel sending was initially described, later on only mustard, but finally people went back to sending because of a less of. And you see the result of sending. 10-year survival is 90%. So you must remember that 1 year survival in TGA is only 10%. 10-year survival is less than 5%. That has become 90%. 20 years around 88%. Not bad actually. They are doing reasonably well. And at 30 years it is around 80%. So you can remember like 90, 85 and 80%. So they are doing well. They are doing well in the sense that they are surviving. They will have problems, but they are still alive at 30. 2, 3/4 of them are alive at 30 years. It's not a bad surgery. It's a good surgery. The only thing is we have got a better surgery. That is why we have chosen what is called a Jettini's surgery, which is called the arterial switch operation. Now here we have to be a little careful because you cut aorta and pulmonary artery above the valve, little above the valve. So you have a small stump there and you have the valve there. So aorta naturally below that will be the aortic valve, which is tougher because it is supposed to support the systemic circulation. Pulmonary valve is little different. Then aorta is connected to the left ventricle, PA is connected to the right ventricle. And the coronaries are actually in the stump, right? So from that it is transferred to the PA. So now it is, and it's a biventricular repair because there are good ventricles. So again I will go through this. You transect both great. Actually what you should do is at home you should draw a diagram of a simple LV and RV and connecting to the PA and just like a TGA, and draw 2 small coronary arteries above this thing and then try to repeat the whole thing. Like you transect both great vessels above their respective valves and connect them to their coinciding ventricles. The route remains the same. So that valve which is actually supporting the aorta is actually pulmonary valve. That is called a neo-aortic valve. Similarly, the valve which is supporting the pulmonary artery is actually aortic valve, which is a neo-pulmonary. So aortic valve is very tough, so they have no problem at all in facing the pulmonary circulation. Whereas the pulmonary valve, now we call it as a neo-aortic valve. We'll find on a long-term basis to find difficult thing. And of course, you have to relocate the coronaries into the neo-aorta, not the regular aorta, into the neo-aorta, just above the valve. So you can see there is another picture here. Okay, this is the picture. I think this, rather than concentrating on this, 3 aspects are there. One, the valve remains the same, supporting the opposite circulation. That is very important. And second, the coronary translocation above the valve, very close to the valve. And third is, of course, simple switches. So it's not a very simple switch. And see, look at 20-year survival is 95. I told you 5% mortality is around 5%, 3 to 5% for an ASO, and those people who do survive, they survive up to 20 years very nicely. So it's a excellent surgery. Rastelli, which is done for a DTGA, VSD, PS, has a definitely a lower survival. 20 years is more than around 60%, but not bad. So survivability, this is very important for your exam also, in real life also. That is 1 year survival without any intervention is 10%, which we know. If you do a balloon septostomy and they go away, they don't return back, the survival is around 30% only. The rest will die. If you do SENI, the survival is about 90%. ASO, it will be 95%. Very good, extreme surgery, and it is an anatomical correction. So we have now the major topic in this previous session was on surgery for transposition, and also importance of balloon atrial septostomy and comparison between balloon atrial septostomy versus prostaglandin in preparing a baby for a arterial switch. And of course, just a peep into what you call as a two-stage ASO, which can be done instead of a simple SENing, but realizing that SENing is also not a very bad option. It is still inferior to ASO, but sometimes, but nowadays I don't think people are doing SENing practically. So back to Rodan and the mic.
Sir, in HS, why do we need to do separate and Fontan separately? Why can't we do separately?
No, PDA may be well developed. The question is, why do we need two-stage? Or, see, basically, we have only one ventricle, right? That ventricle has to face. Which ventricle is that? Right ventricle is there. Agreed. Agreed, no? So, and that, which is basically ultimately that person has to go for a univentricular repair, which is basically something similar to TCPC or a Fontan. The initial thing which we did now was that basically we want to maintain aortic flow to the tissue so that the baby survives reasonably well, so that finally the RV can be entirely, I mean, the whole thing can be converted into a Fontan-like situation. Norwood, of course, technically may be a little different from Fontan, but I have again to admit honestly that I have never been able to fully understand the intricacy of a Norwood procedure. And another point I think I have noted regarding that HLHS, no, that is not there. Okay. Incidentally, one more point I want to stress. Okay, we'll go ahead. That point I will note. Shall we go to the next place?
Sir, one question, sir.
Yeah.
Sir, in two-stage ASO, how much is the duration between two procedures?
Yeah, I think, basically textbook also describe this into two different types. You have a baby, you don't want to lose the baby, I mean, going home and not coming back. So one would be a rapid switch, like you do a PA banding, you create a gradient of at least like 3 to 4 meters per second, that is around 50-60 gradient, and 10 to 15 days later the baby stays in the hospital and we do a rapid switch. That is one. Or previously I think people used to do a BA banding, send them home and ask them to come back after few weeks, and again the attrition rate will be there, whereas here 10 to 15 days in the hospital is a costly thing for both the hospital as well as the person, but that is probably more preferred than the what you call a long duration gap between the PA banding and and arterial switch. Nowadays, I think what happens is that the major issue of not doing an ASO in the right time is not the entry point. It is basically the coronary, some of the coronary anomalies, as you know, because as I will tell you that coronary anomalies in congenital heart disease can be a theory question, especially in a TGA, tetralogy, all those things. So that is the problem with this. And then we have to probably go for a sending procedure, even though everything otherwise is fine.
So what difference between Rastelli and Jettini?
Hello? Yes, please. What is?
Rastelli and
Jettini. Jettini is a Brazilian surgeon. He's a Brazilian because some Brazilians are very good in two things. One you know already. What is that? Football, right? They whatever said, and even if they don't win World Cups, they play much better than any other people. That is one. And many of the congenital surgeons are Brazilians, including our Jettini. So Jettini is a Brazilian surgeon. Rastelli is another surgeon, not Brazilian, of course. He contemplated this surgery for a DTGA VSDPS. So Mustard is another surgeon, and who else? Jettini, Rashkin procedure. These are all important. I think it's very important that you should know these people because they made this possible. So I think just like we remember Nehru and Gandhi and other people, I think you should know this Jettini surgeon.
what is the procedure?
What is the procedure in Jettini? Jettini.
Rastelli and Jettini.
No, Rastelli, see, Jettini in a way is a simple process in the sense that, I mean, at least simple process that you have a right ventricle supporting the aorta and you have a left ventricle supporting the pulmonary artery. So what they do is you cut both the great vessels above the valve, leaving a little bit of tissue there, and then put it on the opposite side. So you have finished that part. Then what you need is that coronary artery has to come from the left, coronary artery supply should come from the left ventricle. So that coronary arteries are cut and located into the so-called new aorta. So two things are done. That is in simple TGA. This is of simple TGA. Suppose there is a VSD also, you close the VSD. Nothing more changes. Whereas if you have a DTGA VSD PS, what will happen? What does this PS mean? It means LV outflow tract obstruction to the pulmonary artery, right? And there is a large VSD. So if you have a large VSD, what they do is they close the VSD in such a way that the left ventricle blood, which is a saturated blood, goes directly redirected towards the aorta. So if they patch in such a way that the VSD is closed and there is a communication between the left ventricle and the aorta, the pulmonary artery may be far away from the right ventricle because right ventricle is giving rise to aorta. So it is far away, already away from the pulmonary artery. And if you close the VSD in such a way that LV has an access to the aorta, the RV still feels very distant. So you put a conduit between the RV to the PA. So what they do is, in simple words, that means that you close off the VSD in such a way that the LV blood is directed towards the aorta. And in that way, because the RV is distant to the pulmonary artery, you put a conduit. So the systemic venous blood will come to the right atrium, to the right ventricle, through the conduit into the lungs, comes back to the LV, good blood passing through into the aorta. And that VSD closure is a very crucial thing, because that closure should be in such a way that the LV blood will be getting there. So that procedure is called the Rastelli procedure, very complex procedure. And if it is done in a younger child, naturally, you may have to revise the conduit, because usually, the adult size, etc. of this thing will occur only by around 10 years.
So can you show us Norwood procedure once again?
That initial stage.
Yes, sir.
See, you have, as you can see from here, you on the right side, you have a good right ventricle, a good right atrium, superior vena cava coming, inferior vena cava is coming, and you have a very small left ventricle, which gives rise to aorta, as you can see in the pink, a very small ascending aorta, valve is atretic, and there are 3 branches, as you can see from there, right? Agreed? And the supply of the circulation is invariably by a patent ductus arteriosus, otherwise the baby will die immediately. So what we do is, this is the on the right hand side is the typical aortic atresia with associated arch hypoplasia. All those things will happen. Now what we do is that on your right, left, or on your left hand side is what is the standard aortic atresia, hypoplastic left heart syndrome. Now on your right hand side, as you can see, is that you cut the pulmonary artery, because pulmonary arteries are good, RV is very good. So you are cutting the pulmonary artery from the right ventricle, right? So that pulmonary artery is getting connected to the so if you cut the pulmonary artery, what you find is that pulmonary artery has to have a blood supply. So far actually ductus was supporting the aorta rather than supporting the pulmonary artery. Now pulmonary artery needs a supply. That supply is done by a BT shunt. Okay, so as of now, ductus is feeding the aorta, mainly in the descending part. Primarily it may go up also, but that is supporting aorta. But that is not good enough. From that, a little bit of blood can go into the BT shunt, but that is not good enough, not only for the forward flow into the aorta or into the pulmonary artery. So what happens is that the RV, because RV pulmonary artery is cut, so that stump, the pulmonary artery stump, is connected to the aorta. And you can see here on your left hand side, the aorta, the root of the aorta and the ascending aorta is much smaller than the rest of the aorta, what is called as aortic hypoplasia. So we want to make the aorta a little more larger so that it can accommodate the entire right ventricular output. So that is why you see a blue patch on your right hand side on the ascending aorta. So what you call as is called a patch augmentation by the surgeon. So if you do a patch augmentation of the surgeon by it, so aorta becomes okay, fine. Aortic atresia is there, but aorta is fine. So that aorta gets blood from the right ventricle. So RA to RV to through the stump into the reconstructed aorta to the body. Good. Saturation may be less, but perfusion is good. And from that aorta, which is getting good supply from the right ventricle, what is you are giving blood. You are lending blood to the lung also. So lung also will feel reasonably comfortable. These are all reasonably comfortable. So that the baby survives. So that is what is the stage 1. Later on, basically, a Fontan procedure, which is much more complex than this. Reasonable. Okay. I mean, you get the principle. So what you need to know is, rather than the actual procedure, the basic principle of this particular difficult kind of surgeries. So for example, this principle you should know, sending this diagram is perhaps the best one which will describe the ascending procedure. And this, of course, will give you the, but this I think, because ASO is a very important area, so you should go back, draw a diagram of a regular TGA and try to put a diagram to this particular slide, and then you will actually understand the arterial switch operation. And this particular slide is, I think, very important for examination. One of my major mentors and my previous HOD was Dr. Taragan. He was the HOD of Sri Chitra, and we have the students like me, from even though we have gone into the 60s, venerate him like a guru. He always tells me, Zulfikar, don't discuss cardiology for an exam purpose. But this is a different situation, because you need what you call as questions and answers for the exam purpose. So if he knows that I have mentioned this term exam, etc., he will be very much worried, maybe a little angry also. Anyway, now we go to another very, very important area. And this important area, Nikhil has put me in a great difficulty. He wants me to later to discuss the Fontan physiology and failure, all those things, which I will try to do. We'll see. Anyway, we'll look at the univentricular heart. Leading lights in 1952. Muller and Deman did the pulmonary artery banding in a single ventricle with severe PAH. Glenn in 54 connected SVC to RPA, which was the original Glenn, which we will see. And of course, the Fontan in 68, who did the Fontan. And later on, nowadays, even though we say Fontan, what we are doing is TCPC, that is SVC and IVC directly to the right pulmonary artery, bypassing even the right atrium. And now I think currently this is a staged Fontan. First we connect SVC to PA, and then later on you connect IVC. So completing, which is called a completion of a Fontan. So now, because we venerate this gentleman, we use these terms interchangeably, Fontan and TCPC. I suppose TCPC was probably introduced in Great Ormond Street. I'm not sure. Fontan, of course, is a. Now look at tricuspid atresia, the epitome. Just like a fallow is the epitome of a reduced pulmonary blood flow with VSD situation. This is an epitome of a univentricular heart. This is really univentricular heart. So what do you do? Majority, 70 to 80%, are having pulmonary stenosis. So they will behave with the reduced pulmonary blood flow situation. Small percent will have pulmonary arterial hypertension, which we will not discuss now. So we are primarily dealing with the tricuspid atresia, restrictive VSD, and significant pulmonary stenosis, behaving like a cyanotic congenital heart disease with the reduced pulmonary blood flow. Almost half of them will present with cyanosis by 1 week, and almost all of them will present with cyanosis by 1 month. Some of them may be stable, some of them may not be stable. If it is a stable baby, we will plan electively TCPC. If the baby is unstable, you have to put a shunt, because blood flow has to improve. If the baby is, this is wrong actually, it should be the other way around. Please note, very crucial point, because once in a while I am uncomfortable with this, more than or less than. If the baby is less than 4 months, you offer them a BT shunt. This is opposite. So below 4 months, you offer them a BT shunt. Why? Because below 4 months, the pulmonary vascular resistance may be little on the higher side. It is still coming down. So if you put a Glenn, a low pressure system, into the pulmonary artery, it will not work. So below 4 months, you do a BT shunt. Above 4 months, you do a Glenn procedure, because Glenn is actually the part 1 of Fontan. But below 4 months, you may have to accept that you may do a petition and later on full-fledged Fontan at particular point of time. So what is Fontan basically? You can basically the central part is important. That is, you are connecting RA to PA communication. That is Fontan procedure simply. And you must have read and you will read this 10 Chaucer's criteria for a Fontan, optimal Fontan. That is a regular Fontan with RA to PA. But now this is different. Now what we do is, first we do a bidirectional Glenn, which we will discuss. Later on, sometime later, definitely sometime later, we connect IVC to PA, either through the heart or outside the heart. So finally, that is TC-PC. Total KO pulmonary connection is the definitive palliation. Now we will take each one step by step. Now there is we call it as a bidirectional Glenn. It's a modern terminology. There was a classical Glenn also. Nowadays it is not done. That I will discuss. But the Glenn which we do is a BDG, is the bidirectional Glenn. That is, we are connecting the cardiac end of SVC. You're cutting SVC from the RA, and that is connected to the superior surface of the RPA near the confluence. And confluence is preserved. What is confluence? The junction, like three rivers joining together. Now you have the MPA, RPA, LPA. That junction is called, you know that confluence. Confluence is preserved. Why? So that blood coming from the SVC, 35% of cardiac output, will go both to the lung, both to the right lung as well to the lung. It is no partiality. It will go to the lung. That is why it is called a bidirectional Glenn, right? So saturation will definitely improve. We will come to that. So original Glenn is different. Original Glenn is RPA is cut and proximal RPA is sutured, and then SVC is cut and connected to the RPA. So what happens is that SVC blood goes only to the RPA, and the rest is the LPA. The blood from the right ventricle goes. Whatever available from the right ventricle goes to the left lung. So there can be a distribution difference between the right lung and the left lung. So this is again generates one question. They can ask you differential vascularity in a congenital heart disease. One reason may be original Glenn, because one lung may get more blood than the other. Or secondly, LPA stenosis in a tetralogy or whatever. So classical Glenn is that. So classical Glenn is not totally gone out. So classical Glenn, the right lung gets blood supply from the, which one? SVC. The left lung gets blood from the right ventricle. And where does the right ventricle get blood? Through the VSD from the left ventricle. So that is what is a classic Glenn shunt. Whereas now we are doing a bidirectional Glenn. And we are doing this. Here what we are doing is, as I told you, you have actually a superior vena cava cut and connected to the which portion? To the right pulmonary artery, very close to the hilum, sorry, not to the junction, so that blood get distributed both to both the lungs, and whatever available from the right ventricle goes to both lungs. So the saturation will remain somewhere between 85 and 90. Baby will be comfortable, and that is actually the first part. What is meant by TCPC? Total KO pulmonary connection. So now we have connected one KO, that is superior vena cava. Then all you have to do later is then connect inferior vena cava into the pulmonary artery, and that will be what we call as a Fontan or a TC-PC. So this is the final picture. You see SVC connecting to the RPA. So blood will go both to the RPA and LPA, and you are cutting off, and cuts disconnect superior vena cava from the right atrium. And that right atrium gets only now IVC blood, which will goes to the ASD and then whatever happens. So glen is an integral part of TCPC, and which I have done. And last is important. What will be the neck vein pressure in a glen? It is equal to PA pressure because it is directly connected to the PA pressure. It's non-versatile flow. What is the advantage? It does not overload the ventricle. Why? Only 35% of blood is going into that this thing, and it goes back to the left ventricle. Decent saturation, and it does not distort pulmonary artery. And most importantly, it is the stage 1 of Fontan. So the next procedure is only 1/2. Now, so part 1 is over. Now we have to complete the Fontan or a TCPC. That is, you have to connect IVC also to the pulmonary artery, which can be outside the heart or inside the heart. Inside the heart, you call it as a lateral tunnel inside the right atrium, whereas the extracardiac is outside. There's a conduit is there, and the age is between 4 and 12 years. Actually, it can be done any time above 2 years, but the usual age is 4 to 12 years. I know, I will tell you why. And the only difference is the easier to do is extracardiac, and now the most popular is also extracardiac. The only disadvantage is that that child will require lifelong anticoagulant because you are using a conduit. Whereas lateral tunnel, basically inside, you fashioned out the right atrium so that there is no need for a anticoagulant. Some surgeons, I think my friends tells me that some surgeons do give only aspirin instead of anticoagulant. That is an institutional policy. Another problem is if you do it, this Fontan completion is done, extracardiac Fontan is done by around 4 years or 5 years, there is always a possibility that the child will grow and you may need a redo procedure. Suppose you do a stable glen, we can even, surgeons feel that we can wait up to 8 years, 10 years, then you do an extracardiac this thing. What can happen is there may not be a need for a repeat surgery. You are left with only 2 surgeries. So these are all practical issues. Again, institutional variations will be definitely there. So Fontan basically makes a heart a single atrium, single ventricle situation. Now the interesting thing, as you know very well, physiologically, it's a very great wonder how it works, because there must be a gradient between the pulmonary artery mean pressure and the driving pressure. Here the driving pressure is only a systemic venous pressure. And how can I put blood into the lung? Full amount of blood is very interesting thing. And the mechanisms are different mechanisms, not the simple mechanistic in this thing. It is a suction effect of the lung will take blood away from this thing. And the skeletal muscle tone, our own lower limb, upper limb skeletal muscle tones are very, very important. And you need a good ventricle and the diastolic function also. What happens is that systemic venous tone drives blood into the pulmonary circulation. So for a glen to work or a Fontan to work, you need a reasonably good physical activity is very important. You have to be physically reasonably active. That maintains the what you call as the skeletal muscle tone and the systemic venous tone, etc., etc. And this is basically extracardiac Fontan, which is done in Suchitra. So the other thing is not done. What is going to do? 2 graphs is put between IVC and RPA. So RPA gets everything. From the top, you get SVC. From the below, you get IVC. And needs anticoagulation and less of atrial arrhythmia. There is less of atrial arrhythmia because it is not going inside the right atrium. Then Fontan. So the Fontan will look like this. You see the blue horizontal, which is the pulmonary artery. So SVC from above, IVC from. This is actually basically what is called as through this thing. This is called the intra-atrial kind of thing, not the this is called lateral form. Now this mortality 5%. 10 years survival, 90%, 15 years survival, 80%, but they will have problems. Morbidity is a very important factor, unlike TG and tetralogy. You can have arrhythmias, protein losing enteropathies, thromboembolic episode, chronic liver disease. Anyway, at some point of time, we will be discussing the post-Fontan issues and the Fontan physiology that we will discuss in detail. There is something called hemi-Fontan. It is more like a Fontan. That is, MPA is interrupted, RA to RPA. So RA to RPA, IVC to PA. It's a little different from the, that is why it's called a Fontan is primarily RA to PA. Whereas TCPC both CAVA to the PA. Whereas hemi-Fontan is RA to RPA and IVC is of course to the PA. So that is why it's called a hemi-Fontan. And there is something called 1.5 ventricle repair, which is again done for a univentricular repair. That is, you do a TCPC and a reasonable preserved RV you may have. In tricuspid atresia, unlike a single ventricle, RV may be reasonably okay. So we don't want to lose the RV's contribution to life. So what you do is you put a conduit from RV to PA, which will also augment the blood supply to the lung. So it is TCPC with RVPA conduit. So these terminology, I think they might ask you what is meant by hemi-Fontan and what is meant by 1.5 ventricle repair. Contemplation. So now we are this particular portion. Nikhil is there?
Yes.
Yeah. What is the time cutoff?
Sir, I think it's 2 hours.
Okay. Now it's already 12.
How much?
Yeah. Okay. Then I will go through that. The rest also quickly.
Sir?
Can I go through that quickly? Little more.
Yes, sir. It's about to finish. We'll finish it also.
Okay, we'll basically you quickly go through the total anomalous pulmonary venous connection, which is you should say the good thing is that supracardiac TAPVC, unobstructed, obstructed. Earlier the surgery, better the survival. Basically simple in a way because the posterior, the vertical vein is posterior to the LA, so it's very easy to connect this thing to the LA. And obstruction is an emergent situation. Unobstructed is urgent situation, and side to side connect pulmonary venous chamber into the LA. Mortality is around 10%. 5-year survival is 85. Now it is much better now. It's almost like 90-95%. And now it is almost 90% stable over the next 30 years. If they survive first 5 years, 10 years, they will survive very well. Very good procedure. AVSD I will skip. We will go just quickly to the Epstein anomaly. You know what is an Epstein anomaly, and now the previous surgery was Danielson or Carpentier. Now the surgery of choice has become cone surgery. We'll quickly go through that, and the indications have become little more liberal because the previous surgeries were not very good surgeries. The current surgery is very good. So the threshold for procedure towards intracardiac repair is little less. Symptomatic patient, increasing cyanosis, increasing RV size, RV dysfunction, LV dysfunction also can occur. And you have the same thing like a DTGA. You have a physiological correction and an anatomical correction. The standard was Carpentier or Danielson, and the anatomical is now called cone surgery. It is not a name of any person. It is a particular kind of shape. The tricuspid valve occurs when you do a surgery. This is Carpentier. What they do is detach the ATL, plicate the annulus. Sometimes you do a tricuspid valve replacement, also ASD closure. Slowly going out to cone procedure, which is an anatomical correction, and it is a correct approach. What you do is you delaminate the tricuspid valve, that is STL from the RV, put it down, and then at the level of ATL, make it into a cone, and the base of the cone is inverted into a normal valve annulus, and the right atrium is plicated, ASD is closed so that nothing is added, and it looks like a normal heart. Mortality is not very high, 5%, and 20-year survival is very good. I think Trivandrum Chitra has a very good experience with cone surgery. Truncus basically is close to the VSD, root LV to the truncus. So truncus will go on to become aorta, RV to PA conduit, so RV to PA. So mortality is around 5%. Only thing is they will require, it's a biventricular repair, but they will need a conduit. And LTGA essentially, if you have ideally you should have a anatomical procedure which is called a double switch, which is actually a combination of sending. That is why sending comes. Sending is still retained because it can be used for an LTGA. So you do an atrial switch as well as an arterial switch. So you have a normal heart, a near normal heart. Then this is basically Chitra experience in tetralogy, less than 2% mortality, TGA less than 4%, TCPC 5%, TAPVC less than 2% now. And I think this information is again courtesy, and many of my information is also from Dr. Baiju, my friend, for his valuable inputs. Then PA banding, I think, is very important for this thing. Basically, this is how they put a band to produce a gradient at least of around 60 millimeter, then to protect the pulmonary artery. Two things: one, to protect the pulmonary artery, and second, control symptoms and maintain a normal PA pressure. Saturation will dip. That is at the cost of a saturation. Gradient, this they will ask you, gradient around 60%, they can ask millimeter of mercury. And that is that. And PA banding nowadays is also done for unbalanced AVSD, which cannot be completely corrected initially. Multiple muscular VSD as a palliative procedure, univentricular procedure, both single ventricle, tricuspid atresia, all those things with heart failure you will do. Then lastly, follow-up, I think aspirin for the modified BT shunt, BDG, either aspirin or anticoagulant, PA banding, none, Fontan, anticoagulant, especially extracardiac Fontan. And this question will be asked in the examination. If you have a median sternotomy, what could be the reason? One, most likely an intracardiac repair. Second, PA banding and Glenn, even though palliative, are done through median sternotomy. And third reason may be a backed out ICR. They would have gone for an ICR, anatomy was not very good, they would have backed out and put a BT shunt or something. So in the examination, when you have a medial sternotomy, you should think these three possibilities in the examination setting. And this, I think, the one point I want to tell you, which one student asked, was the how to assess BT shunt. Yes, this is very important. BT shunt, classical BT shunt, there will be a disparity between the upper limb and both upper limb. An isostigmia will be there and a continuous murmur. Whereas modified, both pulses will be good and high volume, and there will be a continuous murmur. That is the clinical difference. You may get a case of a post-operative BT shunt with other problems. And how do you assess the success of BT shunt clinically? Again, a very important question in the examination. Clinically, look at clinical cyanosis, saturation, radial pulses should be good, murmur should be there, continuous 2/6. Hemoglobin will come down, PCV will come down. There will be small Q in LV leads, V5, V6, and chest X-ray will show a better vascularity, and of course confirmed by your echocardiography. You can go, the rest of also you can go through when I will send to our great friend Nikhil. And I think Dr. Krishna Manohar was my classmate, who is one of the leading cardiac surgeons in the country. So he has said this is a cyanotic workshop. Everybody is needed for this kind of workshop. And finally, you should also know that which conditions are very good results, long-term results, TGA, tetralogy, TAPVC, whereas reasonable would be tricuspid atresia, truncus pulmonary atresia, and a poor result in hypoplastic left heart syndrome or right heart syndrome. So I think we overshot the time. That is why I was a little fast in the beginning, but I thought that if you go through the slides once again when I send to Nikhil, you will understand this. But basically I was concentrating on the tetralogy, TGA, univentricular heart. These are important for you, and Epstein also important for you in the examination. Thank you.
Thank you, sir. Thank you, sir. Any doubts anyone is having?
Okay. So Nikhil,
Sir, it was yes.
what I will do is, I will call you because the first one that very important one, that ECG. So I've tried many times in the single things. I will split the two and send to you.
Sir, I saw it was some 88 MB. So even if you split into two, it won't go.
Yeah,
so,
that is.
And you were telling that Google Drive link is not coming. Sir, we can do one thing. So Praveen, if he's there, I'll talk to him and I'll tell him to teach you, sir.
Of that I will talk to him.
Yes, sir. Now we'll try, sir. After this class, so I will try again.
Okay. Then this I think should go easily. This presentation.
Yes, sir. This is I think 10 MB only.
Only less than 10 MB. So I will send it to you today itself. The rest I will ask the help of Praveen or my friend somewhere. But it will reach you. Don't worry. Then definitely it will reach you.
Yes, sir. People are loving your class, sir.
Oh my goodness.
They all will send the messages, sir. Yes.
Thank you. So we will sign up, right?
Thank you, sir.
Okay.
Yes, sir. Thank you, sir.
Thank you, sir.
Okay.
Thank you, sir.
Okay, thank you very much.
Thank you, sir.